Welcome to 𝗘𝐻𝐻𝐻 podcast by Emirates Hospitals Group. Our goal at 𝗘𝐻𝐻𝐻 podcast is to update you with the latest advancements in medicine, aiming to improve health and well-being. My name is Dr. 𝗍𝗶𝗶𝘀. I am a consultant pediatrician at Emirates Specialty Hospital, Dubai, and I'm the host of 𝗘𝐻𝐻𝐻 podcast. As we know, November is the month that is assigned to raise awareness for men's health, from prostate cancer to testicular cancers and all men health issues. For this, my guest is Dr. Michel Jabbour. Dr. Michel, welcome to 𝗘𝐻𝐻𝐻 podcast, and I will leave you to introduce yourself to our listeners.
Good morning, Dr. Wafa. Thank you for hosting me. My name is Michel Jabbour. I'm a professor and a consultant urologist at the Emirates Hospital Group in both hospitals in Jumeirah and Healthcare City. My main interest in urology is men's health, prostate diseases, erectile dysfunction, infertility, plus endourology, which I hold a fellowship from the United States of America.
It's a great pleasure to have you with us today, especially, as I mentioned before, in November. So my first question will be, what is prostate enlargement, and what are the common symptoms that are associated with it?
Prostate, to start with, is a very small gland by the size of a chestnut. Okay, every man has a prostate, because we have a question: do I have prostate, or do you have? Yes, every male has a prostate. Okay, so we're born with a prostate. However, the prostate, when we're born and before adolescence, is very small. It's by the size of like 5 grams. And once we reach puberty and above, the prostate, with the effect of the hormones and age, starts to grow. And this is what we call prostate enlargement.
Yes.
However, the pathological enlargement of the prostate, we usually see it starting the age of 35. So 35 and above, the prostate can start being pathologically enlarged. So what happens? When the prostate gets enlarged, it will impinge on the urinary tract, called the urethra, that goes through it. So it will obstruct the bladder outflow, causing all the symptoms that are known by most men that we call the lower urinary tract symptoms, or the symptoms of prostates, which are like difficulty to initiate the urine stream, the dribbling, the intermittency, the waking up at night, not being able to hold it for like an hour, having to go frequently, have to rush to the toilet, and sometimes not really reaching the toilet and leaking a few drops. So all these are signs and symptoms of the prostate enlargement.
Okay, so it happens to every man?
Yes.
So it's inevitable. So
Inevitable.
every man will have prostate enlargement. You mentioned the age of 35 years. So this is when it starts, right?
This is when it becomes pathological.
When it becomes pathological.
A man can reach the age of 50 or 60 without having the symptoms.
Okay.
Okay?
Yes.
Because
so it can be enlarged without symptoms.
Without symptoms.
But enlarged for sure.
Yes.
After 35. So those who develop symptoms, are there specific risk factors to develop symptoms? Or how can they prevent it? Men in general.
Actually, it's multifactorial. We have the static component, which is the size of the prostate, and we have the dynamic component, because we do have some muscle fibers around the prostate, and they depend on many factors. Most importantly is the stress. So if we have a very stressed out person, although his prostate is not that very large, he will show symptoms early on, because the dynamic component lead to the fact that the prostate will be squeezing on the urethra and causing the symptoms. Now, so we do have the stress as number one, and the food number two, because we know for sure like hot spicy food will affect the prostate as it affects the hemorrhoids. So we will have enlargement of the prostate and edema. The alcohol will affect the prostate. Okay, we know that caffeine and tea, cola, etc., will affect the symptoms by affecting the bladder and not the prostate. But the prostate is mostly affected by hot spicy food and alcohol.
So stress is always there in
Absolutely.
all the conditions and diseases in medicine. Stress is a major factor. So it's very difficult to avoid the stress. We know this very well, and we can manage. Yes, there are certain tools. Maybe we'll not mention them in this episode, but definitely there is a control over the other stuff like food and lifestyle in general. So starting with the healthy lifestyle to prevent or decrease the symptoms, what are your advices?
It's similar to everybody. The healthy lifestyle is the healthy food and the exercise. Exercise is a stress relieving activity. Okay,
Yes.
so I always advise regular exercises, the cardio exercises. Okay,
Yes.
that will help a lot to reduce the stress.
Yeah.
Now, there are no exercises for the prostate itself, especially when we talk about families, because I missed one point in your question. Yes, there are families where the prostate gets very large.
So there's a genetic
Absolutely. It runs in
factor.
families.
Yes.
So we know that this family, they get very large prostates. The other family, like I take a man of age of 60, he has a 30-gram prostate. Another man by the age of 60 has an 80-gram prostate. Why is that? This is genetic.
Yes.
Okay.
All right. So now we have the enlargement, we have the symptoms, the patient comes to you. What are the treatment options?
First of all, we need to do the assessment. Okay, and this is why what I'd advise to every man starting the age of 40. Okay, because the assessment needs to rule out the presence of cancer, because the symptoms we're talking about are mostly symptoms of benign disease.
Yes.
However, we should not rule out the presence of cancer. Why? Because the cancer is very frequent. Actually, it's the number one cancer in man. So we need to rule out. 1 out of 6 males will develop prostate cancer. So when a man comes with symptoms, all right, in the beginning, we need to make sure this is a benign disease.
Yes.
So we have all the tools now to transform a subjective problem, which is the bothersome symptoms, into quantitative problem. So we have numbers.
Yes.
We have numbers from the size of the prostate by ultrasound. We have numbers from the emptying of the bladder. So we measure when we let the patient urinate, and then we measure how much urine remains in the bladder. We call this the post-voidal residue.
Yes.
And we measure the flow of urine. And once we have all the information in front of us, then we decide whether he needs treatment. Sometimes patients come to do like a checkup.
Yes.
And may go out of my clinic with no medication by
Great.
simply few lifestyle management on how they drink water, okay, what kind of food they should eat or not, the exercise we're talking about, all right, their sex life, because yes, more sex they do, the better will be the prostate, because the ejaculate comes mostly from the prostate, so we empty the prostate frequently. Now, according to the assessment, we decide on therapy. And therapy can start, as I said, from lifestyle management and management of the water intake and the fluid intake in the beginning, to medications, which are now very potent and very effective. And we have a set of medications. Some of them are to release and relax the prostate. Some others are to shrink the size of the prostate with time. And now, if medications do not work, okay, and we give medication and we give it the time, and we see that medications are not effective enough, then we escalate into interventions. So when we are sure that the medical treatment has failed, now we can escalate the management to interventions. In the old days, it used to be only surgical interventions. Now we have a lot of new gadgets, of new minimally invasive procedures that can treat the prostate without carrying the burden or the side effects of having a huge surgery or worse, affecting the sex life of the patients.
These advancements are great, and things are moving really fast in the field of medicine. And for this, we decided to be on this podcast, because what you're mentioning, probably as doctors in other fields, they don't know that now there are certain interventions, not only the huge surgery that we used to learn about it in the medical school before. So before moving to the surgery and the interventions, is there a clear-cut test to differentiate if this enlargement is benign or if this is a cancer in the prostate?
That's an excellent question. There is a test we love it. It's called PSA, prostate specific antigen. It's a blood test. I advise every male starting the age of 40 to discuss with his doctor how and when he should do that blood test.
How frequent in general men should do this test after 40?
The WHO recommendation was on every man starting the age of 50 should have it every year. Okay. Now we add to it, because we're seeing early on prostate cancers, we add to it that we start using that by the age of 40 if we have a prostate cancer in the family. Okay. Or if we are of a certain race, like the African Americans, they have a higher rate of prostate cancer too. So they are advised to start early on. What I advise my patients is, according to the American Association of Urology, is to have a baseline at the age of 40. And according to that baseline, we decide when is the next time. Is it going to be next year, after 3 years, after 5 years, or next month?
Yes. I think the best part that there is this test available for, let's say, precise diagnosis in this
so then we take the test and we go further. I mean, if the test plus the digital rectal examination, which man just, they say jokes about it. By the way, it's not painful at all when it's properly done. PSA and the rectal exam will give us like a certitude of around 90% whether we are suspected of having cancer or not. And then we move on to do an MRI of the prostate if there is a high suspicion. And then the MRI, after MRI, we'll do a biopsy if there is suspicion to diagnose the presence of cancer.
So coming to the benign prostate enlargement, you mentioned certain interventions and, of course, surgical treatments if these did not work. So briefly, I want to know about the interventions and about the surgery and the complications, if any.
Great. So let me start from the least important to me, which is the big surgical intervention, which has become extremely rare. So extremely rare, like once per year, and for a prostate of like 300 grams, we need to open up the patient and remove the prostate. So it's extremely rare.
That's good. That's good.
Of course.
Yes.
Now, the standard form of care is called TURP, transurethral resection of the prostate. What we do is it's an endoscopic therapy. So we go with the spinal anesthesia. The patient will be awake and watching the screen with us. So on a big screen, we start removing chips from the prostate, resecting the prostates with electrical current. Now, the advancement now is we're using a bipolar technology instead of the monopolar, which allows us to resect as long as possible, because before the bipolar technology, we used to stop at 90 grams or 100 grams because of side effects. Like 2 weeks ago, I resected like 150 grams prostate. I resected for 2.5 hours without any side effect on the patient, because we are using the bipolar technology. So this is one advancement that allows us to go for very large prostate with the resection. The problem with the TUR is the possibility of bleeding down the road immediately, or more importantly, for a month period, because the prostate is really a bleeding organ. It has a substance.
Highly vascularized, or what?
It has a substance called urokinase that the cardiologists used to use to remove the clots from the vessels before the era of interventional cardiology. So the patient would be at home and everything is okay, and suddenly he calls me to say, well, I'm seeing blood in the urine, because he made some efforts so he can bleed later on. Now, to circumvent that problem, we have the laser. So the green light laser, which is a nice technology, it will vaporize the prostate without removing chips. The interest in that technology is for patients who are taking anticoagulants. You know, lots of patients who have cardiac problems, hypertension, coronary vascular disease. Absolutely.
The same causative factors.
Absolutely. So they are on aspirin, they are on Plavix, on many things. So if we do TUR, we need to stop the anticoagulants for a long period of time. With the green light laser, we don't need to stop it for a long period of time. So we stop it for a very short period of time, and it vaporizes and coagulates at the same time. So it's a less invasive than the TUR. It offers us less bleeding, less risk of bleeding down the road. Yet, the TUR and the green light laser both entail a risk on the ejaculation of the man. That's why in our parents and grandparents, they used to say, if this patient has had a prostate surgery, he cannot have children anymore. And the layman translated that into he cannot have erection anymore, which is not true. The erection will be preserved. However, he cannot have children because he will have retrograde ejaculation. So the semen will not come out. Although he will keep feeling the same, all right, but the semen will not come out. And this is why they say he will not be able to have children. Now, to manage this side effect, now we have new technologies and newcomers on the market. For example, we have the steam therapy. It's called Resume. That steam therapy is really a very nice procedure because it can be done under local anesthesia or sedation. It takes literally 5 minutes or even less. So by endoscopy, we inject the prostate with steam. So we take the measurements of the prostate, we decide how many injections we need to put, and every injection lasts 9 seconds. So it's literally less than 5 minutes as a procedure. So we inject the steam inside the prostate. In the beginning, the prostate will swell. And then that's why we need to put the catheter. But then with a few days to come, then the prostate will start shrinking. And if I want to explain it in an easy way to the patients, we are bringing their prostate like 20 years back. So the prostate will shrink and the urethra will open. What's interesting about this procedure is the rate of retrograde ejaculation, which is more than 80-90% with the TUR, is only 2% with the Resume. So we're able to do that procedure almost without anesthesia, almost without staying in the hospital, while preserving the ejaculation, and they will be able to stop the medications. That's why Resume is a very nice procedure.
And that's why science is great. But could it be the gold standard for all the cases if it's
No.
very successful and less
it could be a gold standard for certain cases.
Still, the decision is
the trick here is to be able to have them all. So we have the bipolar TUR, we have the green light laser, we have the Resume, we have the Urolift. Urolift is a stapling of the prostate. We have now a new technology called the iTind, where we place a stent, like in cardiology for a while. So it will open up the prostate.
So each case is different as usual.
So the job of the urologist is to know exactly which technology to offer to which patient. Because if the size of prostate is too large, we cannot offer Resume. Okay, it will not work. Although the company may say, well, this is the technology for everybody. It's not true. We know by experience, we know by science that we need to select the patient. And when we select the patients well, we will have the brightest results.
So this is really brilliant. All these interventions, all this technology and these advancements. However, what you chose, now you selected the intervention suitable for this patient. But what about the lifestyle afterwards, like in general? The recovery time? You mentioned bleeding for the TURP, I think, but what about the other interventions?
For the immediate post-op, we advise the patients to take life easily. I insist on them, don't stay in bed, you're not sick, okay? They don't have pain, so they shouldn't be staying in bed. I advise them usually for the first week not to drive for a very simple reason. They will have an urge to void, and if they're driving, one of two will happen. Either they will pee themselves or they will hit somebody with the car. So I advise them not to drive, not to have a strong effort or exertions in the first week, and then go back to gradually normal life starting the second week. By 1 month after the procedures, they will return completely to their previous life.
Gym and sports and everything.
Everything.
Great. So I think the men's health, men are in safe hands with you. Thank you very much for these great insights about men's health, especially now in November. You're telling me it's called now Movember. Movember.
Absolutely.
Yes, thank you very much,
thank you.
Dr. Michel Jabbour.
Thank you for
Professor
hosting me.
Michel Jabbour. Thank you.
Islamic.
And for our listeners, please stay tuned for the coming episode.